Going to go ahead and get started. On behalf of McLaren Macomb, hello and welcome to this educational program on foot pain causes and treatments. I'm Kelly DiNardo, your moderator. We will be hearing from Dr. Matthew Andrews, a podiatrist with McLaren Macomb. At the end of this presentation, Dr. Andrews will be answering any questions that you might have. Please use the chat feature to send in your questions. Dr. Andrews, thank you so much for speaking with us today.
Certainly. Good afternoon. This is a pretty open forum. There's a lot of material to cover here, so I will certainly entertain any questions when we come to the conclusion of our program here. Foot complaints, you often will hear if your feet hurt, everything hurts. So there's a lot of different things that can happen, both that are chronic pain conditions as well as acute pain conditions, and we treat a little bit of everything. So this presentation, like I said, is going to cover a lot of material. So by all means, any questions, we'd be more than happy to answer as best as possible for you. So here's what we're going to talk about today. We're going to talk a little bit about a couple of different etiologies and causes of lower extremity pain. So we'll talk about mechanical foot problems, which are more common things usually just associated with the mechanics of walking, nerve pain, arthritis conditions, and then another very common thing that we see, which is of specific interest, is ulcers and wounds of the lower legs and feet. We'll also cover a little bit about kind of our background, what we do in the area of foot and ankle, surgical and non-surgical management, and then of course we'll leave some time at the end for some questions as well. This is me. I'm originally from Flint, so I'm from the Southeast Michigan area. I was in the military for several years after I got out of college. So I actually started medical school when I was a little bit older. I was 27 when I started in med school. I've been in practice here. I did my residency training here in Metro Detroit, and I've been in practice here for coming up on a decade. I am board certified in both foot surgery and rear foot reconstruction and ankle surgery by the American Board of Foot and Ankle Surgery, and I'm also a fellow of the American College of Foot and Ankle Surgeons, which is a governing body for us. I have a couple of offices. I have offices in Sterling Heights and Ortonville. We also have our resident clinic, which is at the Gratiot Medical Building, right at Metro Parkway in Gratiot, not too far from McLaren Macomb Hospital. I'm currently serving as the director of the residency training program in podiatric surgery at McLaren Macomb Hospital, so I'm very actively involved in teaching residents. I do a couple hours worth of lectures a week, and then we're in the operating room, usually 3 days a week, over at the hospital itself. I consider myself to be a subspecialist in an area of lower extremity surgery that we call limb salvage. So this is essentially has mostly to do with diabetic pathologies, but also I pride myself on, we've had several patients that are sent our way that are told that they're at risk for amputation of the leg. And then we're very aggressive about managing these conditions. And oftentimes we're able to really right the ship, if you will. And then I get referred a fair amount of things for revisional procedures. So we do a number of revision work, joint replacements, fusions, bigger procedures like that. But my goal is always to try to keep people out of an operating room, if at all possible. So what are we? Who is a podiatrist? We are medical doctors that have a DPM degree. This is a medical doctor that specializes in medical and surgical management of conditions that affect the foot, the ankle, and the lower leg. So our education is very similar to that of our MD and DO colleagues. As a matter of fact, my first 2 years of medical school, I was in the exact same classes as all the same MD students. So we attend colleges of podiatric medicine, which are oftentimes sister schools of allopathic or osteopathic medical colleges. And our residency training currently is standardized for 3 years. I did a 3-year surgical residency, graduating a number of years ago. There are fellowships that are available. I did not do a fellowship. Fellowship training is not as common in podiatry. Coming out of residency, I was more than confident handling just about any lower extremities condition, and I didn't feel a fellowship was necessary in my case. There is some variability in training. Podiatry and podiatry education has really evolved over the past, probably 10 to 20 years or so. And now it really has evolved into a modern surgical practice. A lot of folks may just think of podiatrist, hey, that's where you go when you have an ingrown toenail. But really, we handle everything in the lower legs and feet, everything from minor dermatologic conditions like warts and ingrown toenails and lumps and bumps, all the way to major orthopedic procedures. So the foot and ankle, our subject of study today, there's 28 bones in the foot. This is a very intricate structure And it's really amazing that as a normal consequence of walking, that we don't have more problems that we do. 33 joints, over 100 different named muscles, tendons, and ligaments. And these are things that we all had to have memorized when I was in my anatomy training back in school. The average person takes about 4,000 to 8,000 steps a daily. So if you imagine that the average person is anywhere from 160 to 200 pounds, that's several tons of force you're putting over the foot on a daily basis. And of course, some people are walking up to upwards of 15 to 20,000 steps a day. Up to 75% of people will experience foot pain at some point in their lives. So 3 out of 4, and that can be anything. That could be things like an ingrown toenail. It could be heel pain. It could be a nerve type issue, or it could be something major like a diabetic foot ulcer. Women are more prone to experience foot pain, much more so than men. There's a couple different physiologic reasons for this. Yes, some of it does have to do with the shoes that we choose and shoe choice, but sometimes it just has to do with the contact area. Women's feet tend to be more narrow. They tend to be more of a higher arched foot type, so they put more pressure in different areas. And then our feet do grow in adulthood. So from about age 25 to about age 75, our feet will grow an average of about 1.5 sizes. So if you're in your 40s or 50s, the same shoe that you're wearing now, the same size, is probably not the same as it was when you were in your 20s. Our feet do grow. A lot of that is really a gravity dependent process, just how our bodies change over time. Biggest risk factors for problems in the foot and ankle. For us, smoking and diabetes are major problems. People who are pack-a-day smokers or more, every cigarette you smoke, that's really 20 to 30 minutes you're getting zero oxygen to your skin, and that is heightened the farther away you get from the heart. So the extremities are kind of disproportionately affected. So we'll see people that they start to lose pulses, they start to have diminished blood flow, and at some point in time they start to have a lot of pain just associated with blood flow really not getting down to the feet and to the toes. Diabetes, of course, is a major risk factor as well, for some of the same reasons, dealing with vascular compromise, but also things that occur with the nerves, and we don't perceive or feel things the same way. And not only things like diabetic ulcers, but also nerve pain and nerve problems as well. And of course, inactivity. So this has been kind of a challenging year, this pandemic period that we've been going through, because a lot of folks have been relatively sedentary. They're not as active as they once were. And then they start to become active, or they start an exercise program. And oftentimes they're subject to overuse type injuries, or just injuries in general, and including things to do with balance and gait. So there's a number of different things that can affect the foot and ankle, obviously, but these are probably our biggest risk factors for problems involving the foot and ankle. So we'll kind of go through here what our game plan is. We'll talk a little bit about mechanical foot problems first. These are probably the most common things that will bring someone into a podiatrist office. Heel pain being a big one, especially my office in Sterling Heights. We're close to the Chrysler plant, the Sterling stamping plant. So we see a lot of folks who are just standing on their feet on hard surfaces all day. So we'll talk a little bit about all these things kind of in order. So heel pain, this is one of the most common things we see. For every new patient that comes through our door, probably 1 out of 5, or maybe even 1 out of 4 will be for a heel pain complaint. This is extremely common. The 3 different types of heel pain, primarily, the biggest one is plantar fasciitis, which is a very common pain condition that typically manifests itself as first step pain. You take that first step up in the morning, or at the end of the day, you sit down for a while and you go to take a step up, and it feels like someone stabs you right in the bottom of the heel. Oftentimes we look at this as really an overuse injury, but you get a lot of inflammation within the plantar fascia due to these little micro tears that occur, and it can be horrifyingly painful. It can be everything from a mild irritant to really debilitating pain where people can't even walk with it. You may have also heard heel spurs or heel spur syndrome. There is an association with heel spurs with plantar fasciitis. However, a heel spur is largely an X-ray finding. Heel spurs themselves are not what cause pain directly, only in very rare instances. But oftentimes when we see a heel spur on an X-ray, it really just indicates to us that the stress that causes the plantar fascia has been there for a long time, because the heel spur is an adaptive change that occurs. Heel bursitis is another common thing that we see as well. And this is more of just a pure inflammation on the bottom of the foot. So this is activity driven. So the difference between a plantar fasciitis and a heel bursitis is that plantar fasciitis tends to really bother you with that first step. When you first get up, you really feel that pain. Heel bursitis is different. You generally don't have first step pain, but you have pain that worsens with activity. So they're treated very similarly because they're both inflammatory processes, but they tend to have a bit of a different etiology. And heel bursitis is more common in people that have a decreased fat pad at the heel, or they have a more narrow foot and they're standing on a hard surface for longer periods of time, or sometimes we'll see it as an overuse injury as well. And then pain in the back of the heel is also very common. And this is oftentimes more related to pathology associated with the Achilles tendon. So the tendon itself is the biggest, broadest tendon in the body, and it wraps around the back of the heel. And in that area, you're prone to either irritation against the tendon from the bone or problems with the tendon itself. So you can have physical damage or structural damage to the tendon, or you can have like a bursitis at the back of the heel as well, which can be very, very painful. And it has very similar characteristics to other types of heel pain, where you have pain with activity or pain with first steps. Treatment for all of these problems is rarely surgical in nature, especially for plantar fasciitis. It's almost never a surgical problem. Typically, we're able to address it relatively aggressively, but also in a conservative manner. So oftentimes in the short term, we'll consider anti-inflammatory modalities such as oral or injectable steroids, sometimes even the use of non-steroidal anti-inflammatory medications like Motrin or Aleve. And then gentle stretching oftentimes can help work some of that stiffness out. Long-term with heel pain, because it is a mechanical problem, we tend to approach it in a mechanical manner, and we try to do things that will alter the mechanics of how you're walking to keep that stress off the heel. So oftentimes the use of a shoe insert or an orthotic may be necessary to keep a lot of that pressure off the heel, not only to help resolve the problem, but also to help it keep coming back. We also sometimes will employ physical therapy modalities as well, really just an effort to aggressively treat these things without having to consider any kind of a surgical procedure. Of the three of these, the one that does tend to end up in an operating room is Achilles tendonitis problems. And that's really more so because the tendon itself gets some structural damage to it, and sometimes that needs to be repaired. So to kind of piggyback on that point, tendonitis injuries of the foot and ankle are very common as well. These are oftentimes overuse injuries, and they're more often associated with foot type. So people with a higher arched foot tend to have frequently Achilles tendonitis. It tends to be a common thing that we see. Or people that have a very flat foot will have pain associated with a tendon called the posterior tibial tendon, which is one of these tendons that's highlighted in the graphic on the right here. So the pain from the tendons can be pain directly with the tendon, or it can be pain within the sheath. Every tendon that passes around a joint has a sheath associated with it, and that sheath can become inflamed. And oftentimes, if you have just chronic irritation with these tendons, your best bet is really referral for an MRI. X-rays typically don't really show anything specific regarding tendons because they're a soft tissue structure. But oftentimes, if you have a tendon that's not functioning appropriately, or a tendon that's been damaged, you'll have some adaptive changes to the foot. And sometimes you can see things like that in an X-ray. But for the most part, an MRI or sometimes a musculoskeletal ultrasound exam may be appropriate for us to get a better idea of what's going on from a soft tissue standpoint if we're not able to figure it out from a physical exam. Treatment for tendon injuries is pretty straightforward. Oftentimes, we'll undergo a period of rest and recuperation. Physical therapy modalities, gentle stretching, muscle retraining, sometimes even the use of like therapeutic ultrasound modalities and things like that may be appropriate. If it's a structural problem with the tendon, sometimes we'll consider symptomatic treatment like use of anti-inflammatory medications. And then sometimes we'll consider bracing or immobilization. I'm not a big fan of bracing or immobilization for soft tissue injuries. It's okay for short periods of time, but what can happen is if you immobilize a tendon for too long, you get a lot of scar tissue that can develop, and it really, it can kind of slow your progress, and sometimes more aggressive physical therapy is needed to kind of stretch that out. So we're kind of big believers in functional rehabilitation. So bracing sometimes can be appropriate for arthritic conditions, but for tendonitis injuries, we like to maintain motion wherever possible, as long as we're able to do it in a controlled manner. So sometimes we'll even recommend like a semi-constraining brace or other modalities just to help us, kind of rest that tendon for a while and keep it from working too hard. In some cases, tendon problems do become a surgical problem. If it's an acute tendon problem, such as what we call a transection or a rupture, which is common with the Achilles tendon, that's usually a surgical problem. Depending on patient-specific factors, sometimes we can get away without surgery, but oftentimes Either it's a physical damage to the tendon where you rupture the tendon, or the tendon can have things like split tears, and you really just end up with chronic inflammation associated with it. So sometimes surgery is a good option. We almost never would recommend any kind of surgery without an MRI exam. And that's one thing that we strive to do is we try to go through your imaging with you and kind of discuss what's going on and then discuss appropriate treatment options, but also appropriate expectations as well. Sometimes surgery is a good answer, but surgery is an imperfect science. And if anything, I try to give folks a good idea of what to expect. Surgery may not be 100% curative, but it may significantly improve your function and get you better than where you're at now, for example. Bursitis is purely an inflammatory problem. So like we discussed a little bit earlier with the Achilles tendon, one of the very common things that we see, especially activity associated, is this retrocalcaneal bursitis. So that is a inflammatory cushion sac that sits between the Achilles tendon and the heel bone. So in people with a higher arch or people that have an abnormal contour of the back of the heel, as the Achilles tendon wraps around that bone, oftentimes you get a lot of irritation and you can really irritate that bursa in that region. These are typically very amenable to steroid injections and they do very, very well. Sometimes things like a heel lift might be a benefit or a use of an orthotic. And oftentimes the medications like Motrin or Aleve, or even some stronger non-steroidal medications may be beneficial. Typically, this is not a surgical problem either. We're usually able to address this in the office with really injections being the standard of care for these bursitis type treatments. Generally, these injections are a one and done. Sometimes they need to be repeated, but for the most point, usually it's a very straightforward fix. We generally do not inject tendons directly, just because you can actually cause more damage than you're trying to solve. But sometimes some of these pathologies that are associated with a tendon insertion or where the tendon travels in a sheath, a steroid injection may be perfectly appropriate in those instances. Here's another common mechanical pathology we see, and this is a contracture of the toes. This picture is a little bit of a little bit more of an advanced case where you have some rubbing or irritation and you can develop corns or calluses on the top of those toes. Oftentimes, contracture of the toes, or what we call hammer toes or hammer digit syndrome, are just really the result of walking long term. These can be painless in many cases, but in some cases they can be very, very irritating and painful. And you can get issues with rubbing of corns or calluses in between the toes or also on top of the toes where you have like rubbing from the shoe. These are generally a structural problem, and sometimes if they're flexible, we're able to get by with in-office procedures, but oftentimes it does become a surgical procedure as well. One of the easiest things we can do for this is just make sure that you're wearing supportive, appropriate shoes that have appropriate amount of room within the toe box to allow for the toes to expand a little bit. So avoid use of tight shoes. And I typically will recommend like an athletic style shoe that has a like a mesh or a cloth upper over the toe area, so that way you're not rubbing and irritating a lot, and the shoe has a little bit of a give to it. Rigid leather shoes, things like that, tend to kind of worsen this process. In the summer months, it's perfectly appropriate sometimes for sandals just to be able to keep the toes from rubbing or irritating. But well, this is Michigan, and oftentimes sandals is not an appropriate choice of shoe most of the year. There are some commercially available things that can be done for toes, like strappings, sleeves, things like that. Those things are largely of limited benefit. They don't really offer much in the way. They're not going to correct a hammer toe, if you will, but they can sometimes offer a little bit of padding or offloading just to keep the toes from irritating as much. So we do sometimes recommend that type of treatment as well. Another very common thing we see, this is kind of more of a drastic example of this picture, is bunions. Bunions, they do tend to be hereditary. They're really just, sometimes they're just bad luck, but they're oftentimes related to the mechanics of how we walk. So people that have a flatter foot type or that have a very flexible foot type will be more prone to development of a bunion deformity. And oftentimes I see a new patient for bunions and I'll ask them who had them, your mother or your father. They can be, sometimes it's largely a cosmetic issue. And I tell people all the time, I see people that are evaluated for a bunion procedure. If it's not bothering you that bad, leave it alone. Bunions are a deformity problem. They're almost always a surgical problem, but we reserve that for painful deformity. Now, if it's irritating in shoes, if it's giving you problems walking, if it's causing balance issues, those are really the time when it's appropriate to consider surgical management for a bunion deformity. These can be in association with other conditions such as a flat foot type deformity. And they also, like I said, sometimes there's really, just very limited irritation with it. We can get by with things like injections into the joints directly and things like that. But for the most part, they do tend to be a bit of a surgical problem. Non-surgically, we can certainly do things to palliate it and offload it. I've done things as aggressive as sometimes we'll cut a hole in people's shoes just for prominence of the bump. Sometimes a wider shoe can be of benefit. Sometimes some padding or taping modalities may be of benefit too. An orthotic may help to decrease some of the stress on the foot that leads to those abnormal walking mechanics that can cause bunions. But again, there's really nothing that's going to fix it per se. There's a lot of products on the market like bunion splints and things like that. Most of those are largely a gimmick. They're really not going to correct the problem. But again, if they're comfortable to wear and they do provide a little bit of relief, then by all means have at it. That's perfectly fine too. Painful bunions, we generally recommend surgery for. Sometimes we'll even see people on the first visit and they'll say, hey, this is killing me. And I'm the type of a surgeon that I'll try to keep you out of an operating room if at all possible. But for things like this that are pretty straightforward procedure, usually we'll have that discussion with regards to appropriate outcomes. Some bunion surgery really varies depending on the type of procedure. There are some procedures that you can walk on immediately after the surgery, and there are some procedures that may require casting for a period of time. These are almost always elective procedures, so there's never any kind of emergent rush to get a bunion fixed. But oftentimes, having that discussion with us or having that discussion with your foot and ankle specialist about appropriate expectations afterwards and appropriate healing timeline, because the surgery itself is pretty straightforward, but the recovery is really what's going to significantly occupy your time, including things like, hey, if it's the right foot, you can't drive for a couple of weeks, things like that. Here's just a couple of examples of correction of a bunion deformity. So this picture on the left here, you can see sort of a clinical correlation of what a foot actually looks like with what the x-ray looks like underneath. So for the trained eye, you can see that toe is somewhat rotated and not in a good position. And you see the prominence of the head of the metatarsal bone that's kind of sticking out on the inside of the foot there, that's pushing the toe over. So these are two different types of bunion corrections on the right. The one on the top, we call it an Austin bunion, or what we call a metatarsal osteotomy procedure, where we're able to make a cut within the bone and slide the whole thing over and reposition it and remove that bump. And then oftentimes we'll secure that procedure with just a couple small screws in that area to help maintain that correction, which does allow typically for early weight bearing. And it's also a procedure that will help preserve the joint as well. The procedure on the bottom is a little bit more of an aggressive procedure. This is what we call a lapidus procedure, which is oftentimes done in combination with flat foot type corrections. But this is for more severe bunion deformities, where we'll oftentimes go fuse that one of those midfoot joints to kind of bring that whole metatarsal over and to remove some of those abnormal mechanics of gait that are causing a bunion in the first place. So a lapidus procedure, oftentimes that fusion of that joint is accomplished with the use of some implanted hardware. And as you can see, this is a small titanium plate with a couple screws in it as well. So sometimes with a bunion surgery, it will require some implanted hardware, but that's of course a discussion that you can have with the surgeon regarding what's the most appropriate procedure in your case based upon your gait exam and your physical exam and x-ray findings. I've got a couple really great humor in here, and this is something that we see quite a bit. And of course, ingrown toenails is a very common thing that we see. So people always ask me, why did this happen to me? And I usually just tell them, you know what, it's just bad luck. So we're going to shift gears here a little bit here. We're going to talk about another pretty common cause that I see and that we treat relatively aggressively, and that's nerve pain. Nerve pain is difficult because no two patients are alike. As compared to like a bunion or heel pain, our treatments for those are pretty straightforward. But oftentimes with nerve pain, we got to get a little bit more aggressive. And we've got a lot of different tools that are at our disposal. Sometimes we're able to get away with use of topical medications, sometimes even physical therapy modalities, but sometimes we have to consider oral medication or in rare instances, even surgical procedures. So we're going to talk about a couple of different types of nerve pain. We're going to talk about neuritis, which is really involvement of a single nerve branch. We'll talk about neuropathy as well, and then we'll talk about nerve pain syndromes, which can be of mixed cause. So a neuritis is a irritation of a very specific nerve branch. Some folks will say, you know what, I've got burning pain right here, and they'll trace the distribution of a nerve over the bottom of a foot. This is always due to a pinch of the nerve somewhere. And is that pinch of the nerve coming from behind the knee, behind the ankle? Is it on top of the foot? Is it coming from the ankle? Is there some cause? And sometimes the low back plays a role too. So oftentimes if someone comes in complaining of nerve pain, I'll ask them about the lumbar spine. Do you have any problems with your low back? Do you have any imaging that we can review? Because oftentimes that will significantly play a role. If you've got compression of a nerve in a couple different spots, oftentimes if you have compression at the back, it really lowers that irritation threshold for anything downhill. So it makes really any kind of pain condition within the foot a lot more easy to anger the nerve, so to speak. Neuropathy is a bit of a different story. It's a nerve process as well, but it's a metabolic process. So what differs neuritis from neuropathy is neuropathy tends to affect both feet equally, or oftentimes this can be found in the hands as well. And oftentimes this is secondary to another disease process. So neuropathy in and of itself is not a disease. However, it's a secondary effect of some other pathologic process, whether it be diabetes, or sometimes things like malabsorption syndromes or exposure to certain types of chemotherapy medications or heavy metals, things like that. I also did toss in here nerve pain syndromes because these can be very, very difficult clinical problems. And we'll see patients that are referred for everything from medical management to implanted nerve stimulators for nerve pain syndromes. But again, we have a lot of different tools at our disposal. And the one thing I want all of our patients to know is that there's always things we can do. There's always different medications that we can try, different topical medications that may be of benefits, different physical therapy modalities, and in some cases even we'll consider surgical nerve releases or even removal of nerves in some cases. So common neuritis conditions. Another very, very common thing that we see is a compression of the nerve of the forefoot called a neuroma. Now, a neuroma doesn't always necessarily manifest itself as pain. Sometimes it's an oddball sensation, and people will tell me, you know what, it feels like I'm walking on a cotton ball all the time, or it feels like I have cardboard stuck on my foot. Some people would just say, you know what, I've got burning pain and it shoots into my toes. There's a couple different ways people can describe it, but oftentimes they're all describing the same type of pathology. And that's one of these nerves on the bottom of the foot that gets compressed between the bones, between the metatarsal heads. And over time, you can develop some scar tissue around that nerve, and it starts to go a little bit haywire, and you get these oddball sensations or pain that can occur. These are very, very common, especially as we get into our 40s and 50s and 60s. They're one of the more common pathologies that will bring people through the door to come see us in our office. Oftentimes, neuromas are very rarely a surgical problem. I'd say for all the people that come to my office, maybe one person out of 40 will ever end up in an operating room. And that's probably far less than our peers. Our mainstay of treatment for neuromas is typically what we call sclerosing injections, which is designed to disrupt that scar tissue interface around that nerve and really just get this problem to go away. So neuroma surgery for us is not common. I take out maybe 2 or 3 a year, which is probably far fewer than my peers, who oftentimes have a lower threshold to take people to an operating room for this. Surgery is a good answer for neuromas, but it's not always that great of an answer. Sometimes you can have some residual symptoms with it. And anytime you cut a nerve or cut or remove a nerve, the cut portion of the nerve can go a little bit haywire, and you can have some reproduction of your symptoms. So for us, surgery is almost always a last resort for neuromas. Another common neuritis condition that we see is what we call tarsal tunnel syndrome, this is analogous to like a carpal tunnel of the hand. So within the wrist, you've got a nerve that passes through there, and you've got a number of tendons that pass through there as well. So it's a small space, and if you have compression against the nerve, you can have numbness of the hand, and it causes carpal tunnel syndrome. The foot is very, very similar. You've got the primary nerve to the bottom of the foot, which is called the tibial nerve. Behind the ankle, it splits into two, but right in that region, you've got this big dense ligament that covers the nerve, the arteries and veins, and then also a number of tendons that pass through there. So if you have anything that causes any sort of impingement, and this can be something as simple as you have a very flexible flat foot that puts traction on the nerve, it will cause irritation of this nerve, and you'll get these oddball sensations in the entire bottom of the foot. So a pins and needles sensation is pretty common. Some people will say it feels like I have a lighter being held to my foot. It just burns all the time. And nerve pain tends to be more bothersome even when you're off of your feet. So if you have pain that only affects you when you're on your feet, that's oftentimes more musculoskeletal origin, but nerve pain tends to bother you, especially at night. So sometimes that's what will bring people to our office. I'm having a hard time sleeping because I've got this burning pain in my foot. Tarsal tunnel syndrome, of course, can be mistaken for other causes of heel pain. So people will say, I've got heel pain. Well, the default for us is typically plantar fasciitis type pain. But oftentimes it can actually be a nerve irritation or nerve issue. So when somebody is not really responding very well to our treatments for plantar fasciitis, this is where usually the place we start looking next, because tarsal tunnel syndrome can actually masquerade as other causes of heel pain. Oftentimes we'll treat tarsal tunnel syndrome with a sequence of nerve blocks, and then sometimes we can control motion to limit traction stress against that nerve with the use of an orthotic. Surgery is, again, typically not necessary for tarsal tunnel syndrome, but in some cases it does become appropriate if nerve blocks and other treatment modalities have not provided relief. And we've got a couple different options, whether we do what's called a tarsal tunnel release, where we remove some of the soft tissue impingement upon the nerve behind the ankle, or we have a newer procedure that we do, which is a minimally invasive procedure where we do an implanted nerve stimulator as well. So sometimes we'll trial people with which is essentially a TENS unit, which is a type of electrical stimulator. And if they do well with that to manage their nerve pain, we can do an implantable one too. That's more of a long-term indwelling procedure, but that's done as a minimal incision procedure with minimal downtime, and you can typically walk on that immediately. Neuropathy is a little bit more of a worrisome process. The other neuritis type problems are generally very treatable conditions, and they're usually based upon just mechanics of walking or kind of bad luck. Neuropathy in and of itself is related to some sort of metabolic derangement within the nerves. So the nerves aren't conducting an impulse in an appropriate manner, or they're otherwise just not functioning properly. So this can be caused from a number of different causes. By far and away, the most common one that I see is diabetes. So diabetes, if you have uncontrolled diabetes for an extended period of time, you can rapidly develop nerve pain and burning within the feet. And sometimes this is even how we diagnose diabetes. We'll have someone that will come to our office and say, I've had progressive worsening of this burning pain on the bottom of your foot. And that's one of the first questions we'll ask. Do you have any history of diabetes, high blood sugar, anything like that? And they'll say no, but oftentimes you check their blood sugar and it's through the roof, and they had no idea that they had a diagnosis of diabetes. So sometimes we can, it'll manifest itself in the feet first. Otherwise, if your diabetes is well controlled, it can take you sometimes even decades to develop any kind of issues associated with the nerves. We also see neuropathy in the context of alcoholism, which is largely due to a malabsorption problem. In Southeast Michigan, this is a big industrial climate we have here. People that have industrial exposure to heavy metals. My office in Sterling Heights, we're not too far from the tank plant in Warren. So I've had a few patients that worked on tank armor and things of that nature, where they'll have exposure to heavy metals like tungsten and molybdenum and some of these other heavy metals involved in production of tank armor, and they'll develop neuropathy just as a result of industrial exposure. Chemotherapy drugs will commonly cause neuropathy as well. And then another very common cause that we see is bariatric surgery. So people that have had weight loss surgeries, in some cases will end up with a malabsorption issue where they'll start to develop neuropathy symptoms, usually about 3 to 5 years after the surgery. So anybody that's contemplating bariatric surgery, I oftentimes will let them know that this is a potential result. Typically, it's not severe and it's not activity limiting, but it is something that can definitely be a cause. Other causes that can cause this, of course, there's infectious causes. In the developing world, leprosy is still a common cause of neuropathy, as is syphilis. This can be hereditary. It can be related to genetic conditions. And I also throw this term in here, idiopathic. That basically means there's neuropathy of unspecified or unknown cause. I'm not a categorical believer in idiopathic neuropathy. I think there's always a cause. Sometimes it's a genetic issue, and sometimes these things are really due to other underlying undiagnosed conditions. And oftentimes that's a bit of a clinical challenge for us as providers to try to figure out what's the actual cause of this. Regardless of the cause, we have a number of different treatment things at our disposal. And again, neuropathy, much like neuritis, is not a primary disease process. It is the result of some other process. So something is causing this aberrance in the function of the nerve. Some of these neuropathies can become progressive, where over time, it starts with the smallest of nerve fibers, but over time, it will affect large nerve fibers as well. So you can end up with loss of motor function in some cases. And you'll see folks that have had pretty profound neuropathy for a long time, they lose some of the muscular control to the toes. So the toes start drifting and they start going all over the place just because they really have no muscular control. And oftentimes those things can precede ulcers or sores just from the toes rubbing together or rubbing into a shoe. Sensation loss for us, particularly in diabetic patients, is worrisome because it can precede foot ulcers. I've had patients over the years that, due to severe neuropathy, have no sensation whatsoever in their feet, and they'll step on something and not know it, and they'll come into the office, say, "Hey, I stepped on something," and all of a sudden they've got a terrible wound with bone literally protruding out of the bottom of their foot. But I've had people that have stepped on glass and people that have stepped on bottle caps, and they just, they had no idea because they have no sensation at the bottom of your foot. So if you do have neuropathy, or someone that has neuropathy, please be sure that they're checking their feet on a frequent basis, on a daily basis, if possible. We like to catch things before they become any kind of bigger problems, of course. So we'll switch gears here a little bit again. We'll talk about arthritis. These are also very common reasons that people will come into our office. Small joint arthritis within the foot is very common, but it can also affect large joints as well. So we'll talk about a couple different types of arthritis conditions that affect the foot and ankle. And I will make a special space for gout too, because gout tends to disproportionately affect the foot and ankle. About 80% of gout attacks within the body will affect the big toe joint, and about another 10 to 15% will affect the ankle. Gout can really attack any joint within the body, and I'll see patients that have gout flares of the hands, even like small joints within like the ear or the face. You can get gout involvement. That's just a terrible thing to deal with. But thankfully, we've got a lot of newer treatments to help really mitigate severe gout. So we'll talk a little bit about joint disease here first. Arthritis conditions are very typically easily diagnosed based upon plain film x-rays and also clinical history. Usually it's an activity-associated pain or diminished function. I've got decreased range of motion. I've got a lot of jamming in my big toe joint. And these x-rays that I'm showing here on the right are really kind of extreme examples of that. The ankle one especially, that's a pretty severe arthritic change of the ankle, and there's probably very little to no cartilage left in that joint whatsoever. And that's somebody who's probably facing either aggressive bracing or possibly a joint fusion or replacement in that case. And this picture on the bottom here is really a big toe arthritis, and you can see some of the lesser joints. That nice clear space that's there, that's really cartilage, and cartilage does not show up on an x-ray. Whereas if you look at the big toe joint, there's no cartilage left there whatsoever. That's basically just, a bone-on-bone interface with a lot of spurring and a lot of what we call sclerosis or remodeling of the bone right around there. So these can be really secondary either to just primary wear and tear arthritis over time, or also to post-traumatic arthritis, like due to an injury where you have abnormal joint mechanics that leaves you with a bad joint. So primary arthritis, this is more of the wear and tear type arthritis. And this is something that's commonly occurs just as a normal result of aging. So people will come to our office and they'll ask me, is this just because I'm getting old? And I have to find really creative ways to tell them, yes, this is because you're getting old, in a civil manner without having to, really hit them too hard with it, I guess. Oftentimes this is related to your foot type. But also sometimes it's just bad luck just associated with the mechanics of walking. So wear and tear arthritis, especially in people with a high arch, are very prone to it of the midfoot just because of the angle that the bones take when they contact the ground with walking. And also people with high arches are prone to arthritis in the big toe joint as well. People with flatter feet tend to get more rear foot arthritis processes, but it can happen with really any kind of foot type. So sometimes you can have a normal foot, but just some of these muscular imbalances over time will lead to arthritis of joints just from abnormal wearing. So arthritis, we usually call it spurring of the joint or limited motion. And sometimes you'll even be able to feel it. If you've got a big toe joint that doesn't really move, you may feel kind of a ridge or a bump on top of the toe. And that's not a classical bunion in the sense of the word, but we can call them dorsal bunions in the top of the foot, or really just some joint spurring associated with arthritis conditions. And sometimes those can be a physical block to motion. Treatments for arthritis varies widely. Again, this is typically an arthritis process. If we have focal arthritis of small joints within the foot, oftentimes we'll just do small joint steroid injections. And that's more than enough to wipe it out. especially in the acute stage. Oftentimes anti-inflammatories on a daily basis. Motrin or Aleve are typically okay for over-the-counter use, but some people, if they're taking those medications for long periods of time, will put them on a different class of medication like a prescription NSAID that's oftentimes a lot easier on the stomach or easier on the heart. Just because if you're taking some of these medications, if you're just chomping on them on a daily basis, just trying to avoid arthritis pain, oftentimes it can have some detrimental effects to you. We have some newer treatments, including laser therapy, which we'll use for arthritis conditions. We do have an MLS laser in my office in Sterling Heights. Oftentimes bracing or orthotics are necessary. So for arthritis type conditions, we try to use like a softer orthotic that will allow for a little bit of accommodation while also supporting the arch. Midfoot arthritis especially, this is our treatment of choice. You almost never want to have surgery for midfoot arthritis if you can at all avoid it. And typically orthotics or sometimes even aggressive bracing options may be appropriate. And in refractory cases, we'll consider surgery as well. So sometimes either joint fusions, what we call an arthroplasty, which is a remodeling of the joint, or in some cases, we'll even do replacements of the joint. Secondary arthritis is very similar, but secondary arthritis is always related to some sort of a traumatic injury or some other condition. So the most common cause that we see for secondary arthritis is someone who had an ankle fracture that may not have had enough displacement to warrant surgery, or maybe they weren't good candidates for surgery or they didn't want the surgery. But because of the injury, you get some progressive abnormal mechanics or destabilization of the joint. So the joint starts to wear in abnormal patterns, and this wear and tear on the joints over time can lead to deformity, can lead to pain, and can lead to erosive loss of the cartilage. This picture on the right here came right off my phone. This is a good example of a patient who had a high ankle sprain. So that's a discontinuity of one of the ligaments, or a tear of a ligament involving and helping to hold those two bones together, the tibia and the fibula. And that basically destabilized the joint. And over a period of a couple of years, that abnormal mechanics of the joint really wore down the cartilage, and they're really left with a secondary arthritis type problem. Treatment, again, is very similar. We can sometimes get away with steroid injections. Bracing may be appropriate. Oftentimes, these do become a surgical problem just because of the abnormal mechanics of the joint. So anything that we do from a surgical standpoint, we want to restore the stability of the joint, but then also oftentimes get rid of that painful bone-on-bone interface and either replace the joint or fuse the joint. Both of them are excellent options for this kind of thing. Here's a couple examples of post-op x-rays of different folks who have had different procedures for arthritis conditions. This one on the left here, this is one of my favorite procedures to do because it's very brief and it makes an enormous difference in quality of life. This is what we call a hemi-implant arthroplasty. So what this actually is a small stemmed implant that we insert into the bone. We remove a portion of the joint, and then as opposed to having a bone-on-bone interface, you now have a bone on metal, which is essentially painless. It helps to maintain the range of motion, and the recovery is very brief. You can typically walk on this right away. Most people are back into regular shoes within 2 to 3 weeks after a procedure like this. This is a common procedure we do. I usually do a couple of these a month. Oftentimes, anybody who's a good candidate for this may also be a good candidate for fusion of the big toe joint, but we like to maintain motion wherever possible. And then fusion also has a pretty significant downtime associated with it, typically a couple of weeks in a cast. Fusion's a great procedure, but oftentimes, and it is a definitive procedure, but oftentimes these more limited procedures have better results and a much faster return to activity. This picture in the middle is a fusion of the heel bone to the talus bone, which is part of the ankle. This is the joint that connects these two bones is called the subtalar joint. And oftentimes for severe arthritis of the rear foot or in people with really painful flat foot conditions, we will go fuse this joint in place. With that joint fusion, it's very stable and oftentimes very pain-free walking afterwards, but you do lose a very slight amount of range of motion. You lose a little bit of the what we call inversion and eversion of the hind foot. So sometimes walking on uneven ground becomes a little more difficult afterwards, but we typically can compensate for it pretty well. And then the procedure on the right here, this is a newer generation of what we call an ankle replacement implant, which is another procedure that we do a fair amount of as well for severe ankle arthritis. Again, this is a procedure with a relatively limited downtime compared to fusion. Ankle fusion is also a very good procedure in the right patients, but typically involves a couple of weeks of casting and non-weight bearing. Ankle replacements, I usually have you off of it for about 2 weeks and then up and walking on it. So it's really just a joint replacement with a couple pieces of metal to replace the joint and a high density plastic spacer in between. And again, this does maintain motion of the joint. It will never be the same motion as a normal joint, but our goal primarily is, number one, reduction of pain, but number two, also restoration of normal mechanics of the foot as best as possible. I do add inflammatory arthritis in here as well, just because it's a very common thing that we see. So these are inflammatory processes that can affect the capsule or the connective tissue structure that enshrouds the joints. One of the more common ones that we see, and this patient on the right here has pretty advanced case of rheumatoid arthritis, where we see like some soft tissue nodules and things like that on the bottom of the foot, which are just a reactive phenomenon associated with this inflammation long term. So different types of typically syndromic type conditions like rheumatoid arthritis, psoriatic arthritis, lupus is another common cause of inflammatory arthritis. Or oftentimes you'll see it in association with other conditions like inflammatory bowel disease. So people with Crohn's disease tend to have some of these problems as well, especially if it's not very well managed. So oftentimes nowadays we're on biologic medications or steroid medications or some of these immune modulatory medications that really help to limit the effect of some of these inflammatory processes, and then people tend to do well long term. But inflammatory processes involving the joints can be very, very painful, and they can be a pretty difficult clinical problem. And sometimes we're very aggressive about these with regards to surgical or medical management. Oftentimes cartilage is well maintained until later stages in the disease as well. So again, we try to do what we can to palliate these things, or sometimes do accommodative shoes, accommodative shoe inserts. In some cases, we'll consider use of biologic medications to help arrest the inflammatory process. And that can be everything from steroids or other anti-inflammatory medications to medications that really help to limit the proliferation of some of these disease processes. So some newer drugs, like biologic drugs like Enbrel or Humira, some of these drugs you may have seen advertised on television or in print. These medications are wonder drugs for some of the people that suffer from these conditions. And then oftentimes surgery is necessary. Our rheumatoid arthritis patients are always the happiest patients after a procedure, just because they've dealt with pain for so long and with every step that they take. And you can make an immediate difference in the amount of discomfort somebody has with walking. Because if you take away somebody's ability to walk, you can decondition really quick. And oftentimes these people, they really have a hard time getting back up if you sit them down for too long. Gout is a special mention here just because it's very, very common. Gout it was called the disease of kings. And oftentimes there's different causes of gout. But the most common triggers that we see for us is typically consumption of beer, especially darker beers, red meats, and yellow cheeses. It can be anywhere from a mild pain to absolutely excruciatingly horrible pain that will, and everybody tells me the same thing. It's so tender, I can't stand a bed sheet to touch it. That's how painful it is. There is an association of gout with a blood marker called serum uric acid. However, that's not really a hard and fast rule. You can have a normal serum acid and still have gout attacks, or you can have a very high serum uric acid and never have a problem. And in some cases, gout is typically always best to be investigated by a medical doctor or a provider like us, because in some instances, and this is probably less than 3% of people with gout, it can actually be a manifestation of either medication use or sometimes in association with certain types of blood cell cancers that can be really found in this manner. Treatment for gout for us is very aggressive. Oftentimes for us, our primary treatment is a steroid injection directly into the joint. That will knock a gout attack out within just a period of a couple hours. So of course, trying to convince people that's sometimes a little bit difficult. This joint hurts like crazy and you're going to stick a needle in it? Are you nuts? But I tell people it's 5 seconds of discomfort and you're going to love me tomorrow. You'll be sending us edible arrangements and things like that, which has happened before. There are older medications. Colchicine is a medication that's sometimes still frequently given as an oral medication for gout. And then for management of gout long-term, we use some medications like allopurinol and Uloric, which are medications that work on the metabolic pathways that help us to excrete more uric acid within the urine and helps lower the uric acid content of the blood. So for long-term management of gout, sometimes those medications are far more appropriate. And in the short term, also, we can consider use of anti-inflammatory medications. Gout is purely an inflammatory process, and if we can manage that inflammation, that oftentimes we can really limit the effects that gout manifestations have on us. I love high heels. They keep us in business. So our last topic we're going to discuss today is probably one of the most important and one of the most common things that I treat, and can also be one of the most detrimental to your health. And that's really lower extremity wounds, which are a relatively common phenomenon. And oftentimes in association with neuropathy or with vascular disease, sometimes people may not really even understand that they have a problem. They'll come to my office and say, hey, I've got this callus here. But once you clean the whole thing up, you realize this is actually a full thickness wound on the bottom of your foot. So anytime that you have any kind of pain or drainage or any kind of an issue, even if it's in association with another condition like a corn or a callus on the foot, it's best to have it looked at by a lower extremity provider, really just to make sure that you're not having more problems. We kind of delineate this into pressure sores, which can also be diabetic foot ulcers, but diabetic foot ulcers is a separate category, and then also venous leg ulcers, which are relatively common. I had a bunch of pictures that I was going to use for this, which were things that largely just came off of my phone from patients in our office. However, we kind of determined that some of these pictures were a little, it might make some folks a little bit queasy, especially if they have recently eaten lunch or something like that. So I tried to replace them all with some graphics. But hopefully it gets the same point across. This is probably the worst picture I'll show here. So a diabetic foot ulcer, these are very, very common, and about 10% of diabetics lifetime will develop a diabetic foot ulcer. They can be very devastating, especially if you have an infection associated with this, and infections associated with diabetic foot pathology are extremely expensive to the healthcare system. So a diabetic foot ulcer that gets infected, each incidence of that, of somebody that ends up in the hospital, tends to cost the healthcare system on average $12,000 to $15,000. And then if you're talking surgery and things like that, that just adds to it. So why does this occur? It occurs for a number of reasons. Diabetes makes your skin and some of your connective tissue structures a lot more brittle. So if the Achilles tendon in the back of your leg becomes more brittle, it actually works in a functionally shortened manner. So you can put more pressure on the front of your foot. And because the skin's more brittle, it doesn't have that ability to withstand any kind of shear pressure or shear stress when you're walking. And you can literally just really rub these sores, which can start as a blister. They can start as a callus, and oftentimes they'll open up underneath just due to that significant high pressure. Diabetes also makes you a very slow healer. So a lot of folks with diabetic foot ulcers, they really, that's part of the problem is, if you're still putting pressure on it, the more you're walking around on it, you're really limiting the capacity of that wound to be able to heal. So our mainstay of treatment is really offloading. But then also oftentimes these wounds need to be debrided or have some of the non-viable tissue and bacteria and things like that literally surgically excised from the wound, which we'll typically do like in an office setting, but in rare instances does end up in an operating room as well. So other causes of this, neuropathy is often a common cause and often accompanies these, where people say, you know what, I got a hole in my foot and I can't even feel it. I didn't even know what happened. And of course, decreased blood flow too, which helps to limit any kind of healing cells getting down to the foot. That also limits the capacity of us to heal in an appropriate cause. Diabetic foot ulcers are the #1 most common cause of amputation in the US right now. And about 75% of lower extremity amputations, major amputations, which I consider to be a below knee amputation or an above knee amputation, 75% of those are preceded by a lower extremity ulcer, whether it's related to diabetes or related to significant vascular disease, things like that. So our treatment for diabetic foot ulcers is relatively aggressive. We do as best as we can to offload this. So sometimes we'll build up offloading padding within a shoe. Sometimes we need to use custom shoes or custom shoe inserts. Sometimes we need to use a boot, and in some cases we'll even do casting, really just to keep the pressure off these things. So the primary treatment for any kind of wound is to reduce that pressure that's going on. Debridement of the wounds, like we discussed, helps you to remove a lot of the non-viable tissue and expose some of the healthy tissue, which will help to speed resolution of the wound. And then medical optimization. People with diabetic foot ulcers, particularly, if your blood sugar is 250 or 300 all the time, you're not going to heal anything. Your ability to be able to heal things becomes severely impaired if your blood sugar is very high. And that just has to do with some of the molecular mechanisms of healing in the context of too much sugar within the blood. So oftentimes medically optimizing our patients, so control of blood sugar, making sure that we're otherwise trying to avoid other medications that are going to limit healing, such as steroid medications, even inhaled steroids like for COPD or asthma can slow us down. And also chemotherapy medications as well can really slow down the healing process. So sometimes we try to medically optimize our patients as best as possible. We have a lot of products and things that are available at our discretion to be able to try to resolve some of these wounds. My whole goal with any wound of the lower extremity is to try to close it as fast as possible. The longer these things stay open, the more you have things like calcification of the soft tissue, your risk of infection goes up, and there can be a significant stress to your system. Oftentimes, if you have open sores that are in proximity to a nerve, you can have horrible nerve pain with these that really doesn't resolve until you can heal the wound. So we use a lot of synthetic products. We use some donor tissue grafts. We use some amniotic products. We'll use other modalities as well. For larger defects, we'll consider like a portable wound vac, which is a device that helps to kind of remove devitalized tissue or drainage from the wound, and also put a negative pressure gradient against the wound to help it heal faster. Casting, and in some cases, hyperbaric oxygen. Where we're at, McLaren Macomb Hospital, the wound center, they have a brand new access to hyperbaric oxygen treatments as of really the month of April. So we now have that we can offer to our patients as well. So hyperbaric oxygen is a treatment where you sit inside a tank and that becomes pressurized, and we're able to significantly increase the amount of oxygen within the bloodstream through this pressurization, and it will help to rapidly resolve some of these wounds, especially deep wounds or anything that involves any kind of exposed bone. In some cases, in association with diabetic foot ulcers, amputation does become necessary. Our goal, and my personal goal, is to absolutely do everything we can to avoid that. When you remove somebody's leg, their risk of mortality within 1 year is very high. It's upwards of 40 to 50%. So, 30 years ago, people that had significant problems with diabetic foot ulcers, a lot of them received amputations, and they didn't really live very long after that for a couple of reasons. It's difficult to walk with a prosthesis. It can overload your heart. But oftentimes, a lot of these folks, they don't get out of bed, and they just decondition real quick. So the health determinants that lead you to a point where an amputation is necessary, oftentimes, like I said, your quality of life afterwards is oftentimes pretty poor, and the lifespan is significantly shortened. So we're very, very aggressive about limb salvage efforts. And that's one of the reasons why I mentioned I'm kind of a subspecialist in limb salvage. And we somewhat colloquially joke that my goal is to try to keep people's legs attached. Venous leg ulcers, again, the picture, I try not to pick a picture that was too graphic here, but these are a very, very common thing that we see as well. These are oftentimes due to veins within the leg that will cause some dilation just due to insufficiency of the veins, and they really become like a pressure sore from the inside pushing out. So sometimes these will weep, and you can get drainage. Oftentimes it's a clearish to clear yellow drainage out of these things. They can be horribly painful. And these can be small. They can be just little tiny spots that are no bigger than a pencil eraser. Or we have some patients that will have some of these venous wounds that are completely circumferential all the way around the leg. Those are ones that we're obviously a little bit more aggressive with, and sometimes we'll consider synthetic tissue grafting and compression dressings. But again, we're very aggressive about those, and I've been able to heal some of the worst of some of these wounds. But oftentimes it does take a little bit of patience, and sometimes it does take a couple months even sometimes to heal these wounds. Our treatment of choice for venous wounds is compression. This is an absolute must. And you must keep the leg compressed. You must push back against that pressure sore that's pushing from the inside out. So in the short term, we can use things like compression dressings, medicated bandages with compression. Sometimes compression wraps or compression garments may be appropriate. There are even pumps that are available that are, if you qualify for, can be paid by insurance. But for most people, compression socks is the name of the game. Compression socks are tight socks that have a gradient compression that starts at the foot and works its way up. So it's a little bit different than like a TED sock or one of those white socks they give you if you have to have surgery in the hospital. But a compression sock not only will help to resolve some of these wounds, but can also keep them from coming back. So oftentimes after we're able to heal a wound, you'll have to wear a compression sock sometimes for 90 days, 180 days afterwards, really to prevent the risk of recurrence. And sometimes you have to wear them for the rest of your life. We also try to, as best as we can, to medically manage the swelling as well. So sometimes we'll consider putting people on like a water pill for a short period of time. Oftentimes we'll work with primary care providers about medication optimization. to try to help decrease the fluid content of the legs and help to heal these wounds. I've seen wounds that have been open for sometimes 2 or 3 years that if we just aggressively compress them and do appropriate debridements, they'll heal in 2 to 3 weeks. And people think that what we're doing is really magic, but really we're just performing the standard of care for some of these venous ulcers. Traumatic wounds as well. These are a little bit more common in association with accidents, injuries, and we've seen a little bit of everything. One of the common ones that we see is like a knife dropped off of a countertop, for example. Something as innocuous as that can cause a large laceration. I've had over the years everything from people that have been attacked by dogs. I see usually about every other year we'll see a lawnmower injury, usually earlier in the season, so right about this time of year, where people will slip or they'll accidentally run over their foot with a lawnmower, and those can be some pretty significant traumatic wounds. We do see things like accidental gunshot discharges, but oftentimes, regardless of the cause, sometimes our treatment plans vary widely. We teach our residents a lot of plastic surgery procedures. So sometimes our goal is to try to, of course, resolve these wounds as quickly as possible. So sometimes we're able to do like plastic surgery procedures or things to be able to cover large defects as quickly as possible. And sometimes we'll consider the use of VAX or hyperbaric treatments or things like that as well. But like I said, that's always our goal, as best as we can, to try to just resolve these as fast as possible. So I try to give some general wound guidelines for folks here. These are things that are kind of important for people that are managing wounds on their own. I see all the time where people are told, to soak their wound or wash it with soap and water. In the extremities, that's almost never the case. And I tell people, don't soak these wounds. If you get water into a wound, water is a haven for bacteria. So really, you can actually be doing yourself more harm than good, especially wounds on the bottom of their foot. Don't soak these wounds. If you do, if they're draining a lot, sometimes you can dry them out with iodine. Sometimes Neosporin is appropriate, but always have these wounds under the management of a professional. And I also tell people, don't let the wounds air out either. Keep these things covered up, keep your bandages intact. Allowing a wound to air out is, again, just really an invitation for bacteria, or in some cases, flies. I know this sounds terrible and may sound, mildly revolting, but when it warms up like this, we do see some chronic wounds that will come into our office literally with maggots on them. So I tell people, don't let your wounds air out. Keep these wounds covered, and let us just, let the professionals take care of it for you. For difficult or non-healing wounds, a lot of our McLaren facilities, including McLaren Macomb, have a wound center, which is a tertiary referral center for more difficult to heal wounds or more long-term wounds that has more robust resources than some outpatient offices or clinics have as well. And I also tell people as well, don't ignore any signs of trouble. We'll see people with chronic wounds and they'll know something's off. They had an increase in pain, an increase in redness or drainage. And those are indications, to let your provider know right away so we can get you on an antibiotic or otherwise, manage it, hopefully trying to keep you out of a hospital if at all possible. So that's about all I wanted to cover. Just 2 more quick slides here. One of them is why should you see a podiatrist? And like I said, I've tried to illustrate here that, a podiatrist is, a lot of people just think, hey, that's where you go for an ingrown toenail. But really, we do everything. I handle everything soft tissue below the knee or anything bony that involves the ankle or lower leg. So any kind of pain condition, we have a lot of patients in our practice that they just can't bend down and get to their feet. So we'll see people for treatment of their toenails every couple months. So people that have had like a previous back or a hip procedure they can't reach. People who are vision impaired, people who have arthritis in the hands and they can't manipulate a trimmer. And we particularly recommend this for anyone who's taking any sort of anticoagulant or blood thinner medication. So anybody that's taken aspirin, Coumadin, Plavix, Xarelto, Eliquis, any of these types of medications, you definitely should not be trying to treat your own toenails or corns and calluses on your own. Of course, pain complaint, any kind of injuries like fractures, sprains, slips. We do non-invasive blood flow screening in the office too. A lot of folks will have this done at their primary doctor office or their cardiologist office, but sometimes we're another tertiary center that we can catch any kind of blood flow problems before they become bigger problems. We also carry diabetic shoes within the office. We do custom molding for custom inserts for diabetic shoes. We see any and all wounds of the lower legs and feet. And really anybody that has any kind of problems with the foot or ankle, they have difficulty walking or balance issues, any kind of orthopedic problem. So, pretty much anything that you can think of, most of these things we can handle in the office or, within a hospital setting. So That was a lot of activity. There's a lot of me just talking for a good hour straight here. I would like to answer any questions anybody has. These are my primary offices. My primary office in Sterling Heights is Macomb Foot, Ankle, and Wound Care. We do have our resident clinic, which is the McLaren Multi-Specialty Clinic building. That's on Gratiot, just south of Metro Parkway on the east side of the road. And I do have a satellite office as well in Ortonville. That's a bit of a drive for some folks, but we are there a couple days a week, and I do see patients there every other Saturday as well.
Dr. Andrews, thank you so much. This was really good information. I would like to recommend folks, if you have a question, to enter it into the chat, and we do have a couple to get us started. We want to learn a little bit more about plantar fasciitis. Can it be aggravated by wearing different kinds of shoes? And what's the best treatment or ways to help it feel better?
Absolutely. Plantar fasciitis it kind of has a mind of its own sometimes, and it may really not matter what shoe that you're wearing. It's typically worsened with a flatter shoe, like a sandal or ballet flats, or anything that's just not supported or doesn't have like a thick cushion for it. So for people that have issues with plantar fasciitis, we try to treat it relatively aggressively, and most people do not have recurrence. Once we're able to kick it out, it's usually does not recur. So typically, the best shoe for plantar fasciitis is going to be something that has either a bit of an arch to it or something that has like a thick sole. So for like walking or running shoes, I'll typically recommend a New Balance or a Brooks shoe, just because they've got a wider platform, thicker cushioned heel. Some of the Skechers shoes are fine also. I usually don't recommend the Skechers memory foam shoes, just because they don't really have much in the way of mechanical support for them. They may be okay if you're using it with an orthotic, but I usually don't recommend those shoes. So that's, typically that's one of the mainstays of treatment. And there are some shoes that do have like an integral arch built in. In the summer months, I'll recommend like Birkenstock style sandals. And there's also a brand of shoes called Abeos, which is ABEO. They're carried at a couple shoe stores. I know they're at the malls here in the Metro Detroit area, at Somerset Mall and at Partridge Creek Mall. There's a store called The Walking Company that does carry these shoes, the Abeo shoes, and they have an arch built into them. So for women, especially that are looking for something that's a little bit more stylish options, or sandals like in the summer, that's also an excellent choice. Treatment for heel pain really is based upon symptoms. So if you come in and say, I've got mild discomfort, it bothers me periodically, it's not every day. Sometimes we'll just recommend, we'll do like a strapping of the feet that will simulate what a custom insert would feel like, and we can evaluate you for custom shoe inserts. Sometimes we'll make specific recommendations. We may recommend a topical medication like a Voltaren gel, or possibly even like a topical compound medication, or sometimes even, maybe even like an oral medication. For severe heel pain, we have a pretty well-defined protocol in our office, and we'll typically do, as opposed to doing like one big steroid injection, we'll split it up into a couple small ones and space them out over a period of a couple of weeks. We found by doing so, we get a lot better long-term pain relief. And because heel pain tends to be a chronic inflammation condition, oftentimes we can just kind of get you through that chronic irritation and resolve it. And like we said, heel pain in very, very rare circumstances does it ever become a surgical problem. We do everything we can to try to avoid it, but for most people, that's rarely an issue. Usually we're able to treat it aggressively. And oftentimes if you have refractory heel pain, it's related to other causes like, like a structural problem, like a plantar fascial tear, or sometimes even like a nerve impingement, like a tarsal tunnel syndrome.
Another question here. I have very flat feet, bunions and calluses on each of my big toes, so on the outside of the toe. Would surgical correction of the bunion improve the calluses or the flat feet? I hate wearing orthotics.
Possibly all of the above. Oftentimes, if you've got a really flat foot, you get a lot of calluses, especially on the inner portion of the big toe and the big toe joint. And the reason why is because when you have a flat foot, you tend to rotate your foot outward a little more when you're walking, and you just kind of roll over that big toe. I tell people this all the time. You'll probably notice it now that I point it out. So you really roll over the toe and you get those calluses that occur. Orthotics can help to an extent, but depending on how flat your foot is, oftentimes a surgery procedure may be appropriate. In those instances, oftentimes we can do bunion surgery, but we oftentimes will approach it as a flat foot condition. So we can do other, really just more of like a flat foot reconstructive type procedure to give you, establish a normal arch and really help to increase the efficiency with which you're walking and restore some of the normal mechanics of gait. And then those lesions tend to go away almost immediately after the surgery for the most part.
I have a question when you talk about surgery for flat feet. Do you do one at a time to allow for healing in between, or what's the process?
You'd have to do a pretty good job of convincing me to do both at the same time. In very rare instances do we do that, because most flat foot procedures typically involve some degree of casting and non-weight bearing afterwards. So I generally recommend, if you're going to do both feet, try to we usually space them out maybe 6 to 8 weeks apart, or typically longer. I generally recommend having like one foot to get around on, just to be able to use a crutch or a knee scooter, just to be able to get around on. Because if you have surgery on both at the same time, that would be a period of time where you really just, you'd have to be completely off of your feet. So you would be either like wheelchair bound or bed bound. And that's not necessarily ideal for recovery. In very rare cases, we would entertain something like that, like if there's a narrow window of time that someone can be off of work. But oftentimes in those scenarios, if somebody's considering a surgical procedure with us, we'll do like FMLA paperwork or short-term disability. And those are things that we just take care of in the office.
Another question here. What is the best conservative treatment for hypergranulation tissue alongside ingrown toenail?
Boy, as best as possible, probably just put some lidocaine on it. That's oftentimes that overgrowth of tissue, that hypergranulation tissue, is an association with a nail that's actually protruding into the skin. So those things like to become infected real easily, and they like to have a lot of drainage and just cause a lot of chronic pain. What I generally recommend for that hypergranular tissue is really just removal of the offending portion of the nail. If we can take a small sliver of the nail out and keep that pressure against the side of the nail from occurring, and keep that nail from cutting into the skin, it really solves the problem pretty quickly. And that's a procedure we just do quickly in the office.
I think that was it. I have recently seen on my Facebook news feed shoes that look like they realign your ankle. Have you seen those?
There's a few different things that will advertise on social media, like Vionic shoes, which is a common one, or different types of arch supports and things like that will be advertised. Some of that stuff may offer a benefit, and I try to solicit everyone's feedback on it. So as far as I'm concerned, for something like that I don't have a lot of experience with, the jury's out, and I always solicit people's feedback. So different types of shoes that are specific for heel pain, for example, or for people that will get like a shoe that's advertised specifically for plantar fasciitis, or even some newer treatments. Like in our area, we're seeing a lot of folks that will use CBD oil or CBD products as adjunct treatments, for pain conditions. And I just try to get everyone's feedback on this, because there's not a lot of good publishable data out there. So some people have good success with these products, and some people have kind of negligible results where they really don't see any benefit.
You may have already answered this question because you talked about shoes with memory foam. What's your feeling on Crocs?
Believe it or not, Crocs are actually recommended by the American Podiatric Medical Association, which is one of our political bodies. It's an arm of the AMA. Crocs are actually fine. I recommend them in a lot of cases because they have a bit of an arch to them. They're soft. So for some people that have like arthritis conditions, especially the midfoot, that's a fabulous shoe choice. I typically recommend a Croc that has some protection for it, like the ones with the holes in it. That may not be all that beneficial, just because you can get a lot of dirt and debris that can accumulate in there. But believe it or not, I actually wear Crocs in the operating room, and I've got a pair over in my locker over at McLaren right now.
Okay. I think they're comfortable. Okay, another question here. What about Charcot foot? My husband was finally diagnosed with it, but by then he had 5 broken bones in his foot.
Charcot foot it was named after a French neurologist named Jean-Martin Charcot. It is one of the most devastating conditions that we treat. And that's oftentimes the problem, is that there's a bit of a diagnostic delay. We'll see folks that will have like it would typically manifest itself as a red hot swollen foot. So you go to an emergency room or go to like a primary doctor's office, and they'll say, oh, this is, it's an infection, because it looks like an infection. But oftentimes there's no open wounds, there's no lesions with it. Sometimes there can be wounds, but oftentimes there's a bit of a delay in diagnosis. So to the trained eye, this is something that I'd be able to pick out almost immediately, but sometimes there's a bit of a delay in the time that comes to us. So people will get put on an antibiotic, and which may or may not help the redness of the foot. But then what happens is it's actually a metabolic process that causes wasting of the bone, and then the bone just becomes weakened and subject to multiple fractures. The midfoot is the most commonly affected, but also the rear foot can be involved as well. Charcot is something that we try to manage very aggressively. Sometimes it will result in surgical management, especially if you have multiple fractures. Sometimes these feet need to be stabilized. But it's one of those things where, and I tell everybody up front, there is a significant risk, as much as possibly 25%, that regardless of our best efforts, that you may be facing amputation of the leg. Our goal is obviously to avoid that at all costs. But oftentimes, I said it's a difficult condition, but we've got a lot of good treatment options to be able to surgically stabilize, and oftentimes we're very aggressive. So I typically recommend for Charcot foot, make sure that you're seeing a provider that's board certified in what's called rear foot reconstruction and ankle surgery. There's a number of us in the area in Southeast Michigan, and a number throughout the state of Michigan, myself included. And that's one of those things where I typically will recommend, second opinions are always a good idea as well. It's a very tough process. And oftentimes Charcot is accompanied by neuropathy. So you may really not feel what's actually going on, even though you're causing a lot of damage to the foot just by the normal process of walking.
Very good. I believe that was our last question. So thank you so much for all this information. Really appreciate you spending so much time with us today. And we wish everyone a great afternoon. Thank you.
Absolutely. Thank you, everybody.